The objectives of this talk are for you to be able to list the sonographic findings suggestive of adenomyosis, to explain the common sonographic manifestations of uterine myomata, and to describe mechanisms for uncommon sonographic presentations of uterine myomata. First of all, let's start by reviewing the layers of the myometrium. The highest echogenicity is that of the endometrium. Right around it is a hypoechoic band, which is a thick band of compact hypoechoic inner myometrium. So that's the first layer of it's not the basal layer of the endometrium, it's the myometrial layer. Then comes the thickest part of the myometrium where the muscle is. It's moderately echogenic and where various circular and longitudinal muscle is located. Then comes a fairly thin outer layer, which is pretty much isoechoic with the intermediate layer, maybe slightly less echogenic, and you'll see vessels in between layer 2 and 3. And those vessels between layer 2 and 3 are the arcuate arteries and veins. Basically, there's really no visible vessels within the intermediate layer. Now, these arcuate vessels are located approximately 5 millimeters under the serosal surface of the uterus. As we can see here, the vessels come in along the lateral aspects of the uterus, come around the periphery, and send branches into the myometrium. Now, these vessels can be very prominent in some patients, especially the veins. They can be as prominent as in this patient, but this is still normal in women of childbearing years. These vessels are sometimes serpentine, very tortuous. They're tubular, fluid-filled structures that go along the periphery of the intermediate layer. Here's an example of a large vein coming across, and we can Doppler do a spectral tracing on it, proving that it is a venous structure. Now, the arteries, I mention these because the arcuate arteries are also located in there, and eventually they may calcify in older patients. And then they become hyperechoic foci, some with shadowing, some don't really shadow because they're very fine calcifications. And they really represent cystic medial necrosis, or this pathologically speaking Monckeberg sclerosis. So these dystrophic vascular calcifications represent the location of the arteries. And when we see these, they're usually postmenopausal women, so it's not unusual to see it. It is more common with diabetes and hypertension, although that's not to say that a patient who has these does have diabetes or hypertension. So just so that you are familiar with the distribution, 5 millimeters under the serosal surface echogenic foci. Now, sometimes the calcium is dense enough that it can cause acoustical shadowing, and that may actually cause so much attenuation, shadowing, that it may actually obscure the endometrial cavity line, and sometimes may even fool you and simulate a hydrometrium. This patient, you can still barely make out this endometrial line, but in some patients it looks like a hypoechoic center and should not be mistaken for a hydrometrium. Another little technical point about the myometrium is that sometimes you will see increased echogenicity within the myometrium, but you should make note, is it behind secretory endometrium? So when the secretory phase is present, these little glands fill with mucus. There's increased water content that then increases sound transmission and may make this posterior myometrium look hyperechoic. So that's just an artifact and should not be taken for pathology. We have little tiny so-called myometrial ditzels, the little tiny abnormalities in the myometrium, which really are clinically insignificant. Some of them have some pathologic significance, but you may see tiny punctate echodensities throughout the various layers of the myometrium. Most of the time we don't even know exactly what they come from. Sometimes we do think we know a specific cause for them, but here are some examples. This is probably along the inner layer. Here's a little clump of echogenic foci. Here's a little tiny calcification with shadowing. Here again, echogenic foci along the edge of the inner, hypoechoic zone and around here. Now sometimes, and this has been proven pathologically, that this represents, quote, placental site nodules, which are these little focal echodensities at the endometrial-myometrial junction. They probably represent the site of a prior pregnancy implantation. When these were evaluated, the only thing they found in common was that the women had at least one pregnancy. If you look under the microscope, it's a benign lesion of intermediate trophoblast. Now, as soon as I say trophoblast, you're not supposed to think of potential for gestational trophoblastic disease or malignancy or anything like that. This is just how pathologists classify it. There have been no reports of this degenerating. Microscopically, they are well circumscribed nodules, and that's why we call them ditzels, because it's just a little collection of things. Sometimes these little ditzels are actually small fibroids, and these three examples here of old calcified involuted fibroids common in postmenopausal women. We can see scars. The first three here are representatives of cesarean section scars. That's in the lower uterine segment. Often you can see a puckering of the anterior contour and associated with some type of triangular defect. In this case, it's echogenic. In this case, possibly calcified. And here is a small cystic changes. So you will see a variety of appearances, sometimes just a fluid-filled cavity. One should pay attention to the thickness of the covering myometrium. If you see that it's extremely thin, that would be worth reporting to the clinician. And this is the site where ectopic pregnancies sometimes like to set up households. So that covering of myometrium, if it's extremely thin, that could be the site of a dehiscence. Here is another myometrial scar. This woman had a myomectomy, had a hysteroscopic removal of a fibroid, and an area, a small little scar calcified in her uterus. Here's a sonohysterogram that shows us filling of a myomectomy defect, sort of almost a diverticulum that comes off of the endometrial cavity. This has been described in the literature. Here's another patient who had had a surgical myomectomy and developed a hematoma and eventually an area of scarring within the myometrium. By the way, there have been reports of ectopic pregnancies establishing implantation in some of these sites as well. We used to think that it was impossible to have a pregnancy within the myometrium, but now with all these surgical procedures, it is actually possible. Now, sometimes the clinician may ask us to evaluate the uterus prior to endometrial ablation. What they're asking us to do is to comment on the myometrial thickness. They would like to have, or they need to have, more than 10 millimeter thickness of myometrium. So they're going to ask us to measure the thinnest myometrium, because if the myometrium is too thin, they will not be able to do the procedure. Because as they go into the endometrial cavity and wave around their instrument, which could be a number of different ways. It could be a laser beam. They can use thermal destruction, electrical destruction, freezing, microwaving of the endometrium. So whatever they use, that can actually penetrate heat or damage something beyond and cause further problems. So they want to have a nice thick covering of myometrium. So our job will be to measure the thinnest parts, not the thickest. So here would be the thinnest, not this thick part. Also make note of scars. So if there's a C-section scar, they will not be able to do that because of penetrating damage.